So hello everyone, welcome to my another video. So today's topic of discussion is adenomyosis. So this topic is from the gynecology section. So let's look at this topic. What is actually adenomyosis? So it's a benign disease of the uterus which is characterized by ectopic endometrial glands and stroma within the myometrium. So in this disease what happens that when the endometrial glands shed off, they don't easily come through the uterine cavity and they get trapped, so which causes the uterine pain actually. So we will be looking into all of these points in the upcoming slides. So let's start them one by one. So it's associated with myometrial hypertrophy and may be either diffusive or focal. In chronic pelvic pain in which women had hysterectomies, the incidence of adenomyosis is about 15 to 25%. Please keep this percentage in mind because it is a good MCQ. So adenomyoma is a focus of adenomyosis within a fibroid, and this is the one of the most important point from this topic, that adenomyoma is a focus of adenomyosis within a fibroid. MCQs can be asked from this section, so keep that point in mind and have a note of it. The gland tissue grows during the menstrual cycle and then at menses tries to slough. The old tissues and blood cannot escape and they get trapped. So this trapping of the blood and tissue causes uterine pain in the form of monthly menstrual cramps. And this is the point which I was talking about, that in normal menstruation the menses come down easily through the uterine cavity, but in case of adenomyosis they get trapped. They don't have a way to come down through the uterine cavity, and that trapping causes the uterine pain in the form of monthly menstrual cramps. So it also produces abnormal uterine bleeding. Hope you are able to connect to the points. So have a note of it. So in this point I have mentioned that in normal menstruation the menses come down through the uterine cavity. That is from the that is when the endometrial gland shed off down the uterine cavity. But in case of adenomyosis it is not so. So I already discussed about this point. In case of adenomyosis, the cause of uterine pain is that trapping of the endometrial glands which are shedded off when they don't find a way through the uterine cavity, and that causes the uterine pain in the form of monthly menstrual cramps. So we already looked at that point, and I hope you are able to connect with it. So now let's look at the associated conditions: fibroid uterus, endometriosis and CA endometrium. So what are the symptoms? Pelvic pain, backache and dyspareunia. Progressively increasing dysmenorrhea. So dysmenorrhea means painful menstruation. You all already know that. So let's look at the other symptoms too. Progressive menorrhagia, unresponsive to hormonal therapy or uterine curettage. Subfertility or abortions. So what are the classical presentation? Cyclic cramping uterine pain beginning later in the reproductive life. Generally it is seen after the age of 35 years, and often it is associated with prolonged and heavy menses. And Paris woman around 40s, uterus symmetrically enlarged from about 6 to 14 weeks pregnancy size, and the uterus can feel soft and baggy on pelvic examinations. And sometimes adenomyosis is associated with uterine fibroids. So this point is very important, keep that in mind. So repeated bimanual examinations over several months just before and after menstruation have been recommended to detect the fluctuating changes in the contour and the consistency of the uterus too. In hysterography, it shows the presence of ill-defined areas of contrast intravasation extending perpendicularly from the uterine cavity into the myometrium, and it is the most important characteristic feature of adenomyosis on hysterography examination actually. So this is all about the hysterography examination, but unfortunately the sensitivity of this technique is too low for clinical practice. Please keep this point in mind, that the sensitivity of this hysterography technique is too low for clinical practice. And have a note of it. Let's look at the other points too. So on ultrasonography and transvaginal sonography, it will have ill-defined hypoechoic areas, heterogeneous myometrial ecotexture, and small anechoic lakes, and these small anechoic lakes are the places where the collection are there actually. So the collection of the shed of endometrial glands is been talked about here. So keep that point in mind. Asymmetrical uterine enlargement, indistinct endometrial myometrial border, and subendometrial halo thickening. The most predictive is the ill-defined heterogeneous ecotexture within the myometrium, and this is the most important point which can be asked in the MCQ. So now let's look at the MRI. So MRI should be expected to be excellent in recognizing uterine masses like fibroids, cysts and adenomyomas if they reach 5 mm or greater in size. And MRI may be able to lead us to expect adenomyosis if the myometrial thickness is increased or the consistency of the myometrium is changed. Then only MRI will be able to lead us to the detection of adenomyosis. And MRI was superior to TVS, means the transvaginal sonography, for the diagnosis of adenomyosis showing hypo or anechoic areas. MRI also had a greater specificity than the transvaginal sonography, but their sensitivities were high, that is in line. So please go through this topic for once. So let's look at the diagnosis of the adenomyosis. A good gynecologist may suspect adenomyosis based on the clinical factors, but the final diagnosis can't be made until the hysterectomy is performed, because hysterectomy is a practical procedure. So we always rely on the practical procedures because it is the best examination to detect that problem, isn't it? So have a note of it, and let's look at the management. The GnRH agonists, which reduce the adenomyotic uterine size and may facilitate fertility. In case of infertility before laparoscopic surgery, greatly decreases surgical difficulties and blood loss in certain cases. So in case of GnRH agonists, they perform these two tasks. Mirena is an IUCD for menorrhagia, which releases progesterone. So these two medicines can be used over here, Mirena and danazol. So have a note of it. Localized excision in case of localized adenomyosis is one of the management, and TCRE, transcervical resection of the endometrium, is the another management associated with adenomyosis over here. So let's look at the uterine artery embolization, UAE. So UAE is an effective and safe method in treatment of these adenomyosis. So the recurrence rate of this UAE, uterine artery embolization, is not yet evaluated. So we'll be getting to know about it in future. So keep that point in mind, that currently the total hysterectomy is the only definitive procedure for the treatment of adenomyosis, and in younger patients we conserve the ovaries in this procedure, but in case of menopausal or the premenopausal patients we don't conserve the ovaries because there is no need. So I hope you enjoyed the lecture. Hope this helps. Keep watching, keep supporting, and if you are new to my channel, please subscribe.